We'll move on to minerals and trace nutrients here, and we talked about all of these vitamins that are important, particularly, well, definitely for anybody, but particularly during childhood when during growth. Uh, Minerals and nutrients, these are very important during childhood because uh, usually when you see a manifestation of a mineral deficiency, it's because the person is growing and they need more of these minerals to incorporate into cells for enzymatic activity, for cell function. And so the more you're growing, the more minerals you're going to need. Now, we tend to just need these in very small amounts. So when we see these deficiencies, it tends to be in children. As we're going to see with iron, the amount of iron that a little girl needs is actually more than what a grown man needs. So we're going to talk about iron deficiency and iron poisoning. And iron poisoning used to be a really big problem. It's actually dropped off a little bit because of some changes that we've made in the manufacturing industry. We'll talk about that later. Iodine, magnesium, zinc, and copper I felt were the other four more important minerals. We'll talk about then these other four, which we'll just pretty much just give them passing mention. But the ones you really need to be familiar with are iron, iodine, and magnesium. I would say these three are the most important for the test. So we get our iron from two sources in our diet. We get it from meat and seafood, and this is really the best way to get iron. If you're just looking at it neutrally, this is the best way to get iron because it has better bioavailability, and so the amount of iron that's in that food, that particular food, you're going to absorb more of it. Whereas with some of these other sources, the non-heme iron sources, it may have a lot of iron in it, but not as much of it is going to be absorbed. But these are still good sources. So fortified cereals, a lot of breakfast cereals that you get if you walk down the breakfast aisle are fortified with iron, and that's really good because particularly if you're a vegetarian or you're not eating meat a lot, then this is a great place to get your iron. Nuts, beans, vegetables, and then my favorite is dark chocolate. So a lot of people take iron supplements, especially if they've been previously diagnosed with a hypochromic anemia. So that's perfectly fine. Most multivitamins intended for women contain the recommended 18 milligrams of iron. Because women menstruate, they're at high risk for iron deficiency because they're bleeding for 3 or 4 days or more, even in some pathologic states. They're bleeding every month, and so they need to replenish those stores. So I put down here the RDA. Don't memorize it. But what's useful to memorize is, or useful to take into mind is the fact that children need more, in many cases, need as much or even more iron as grown men. So babies 6 months to 12 months of age need 11 milligrams of iron. You compare that to a grown man, he only needs 8 milligrams of iron. Even a little girl who's 6 years old, she needs 2 more milligrams of iron than a grown man. Now, when a woman is pregnant, she's going to require 27 milligrams of iron. So that's up about 50% from what she would normally take. And that's just because she's making blood or supplying iron for 2 rather than for 1. And then finally, when she's lactating, that iron requirement is actually going to be less. And you might be able to guess why that is. I'll give you some time to think. So while she's lactating, she actually needs less iron because she's not having her period. So she's not losing blood. She only needs roughly about, a little bit more, but roughly about as much iron as a male counterpart. So she'll need a little bit more because she is breastfeeding, and that does take a toll on the system. But she doesn't need as much as she would otherwise need if she were having her period. So people who are at risk for iron deficiency, big one we think of in pediatrics would be infants, particularly those who are breastfeeding, and they sort of have this period after they're born where they have a good amount of iron stores, um, but after about 4 to 6 months, if they're breastfeeding, those stores are going to start to deplete, and they will become hypochromic anemic. So it's suggested that children who are breastfeeding, and breastfeeding is always a great way to go. It's preferable to formula feeding as long as you can do breastfeeding. I'm not trying to make it sound bad. It's just breast milk does not have quite as much iron as would be desirable. So it's advised that about 4 months you start supplementing baby with iron. Now, if they're on formula, the formula already contains a sufficient amount of iron for the baby. Of course, children who are growing, so you go back and look at this chart here, and you see that children who are going through their fastest stages of growth, particularly 6 to 12 months, which is they're going to need 11 milligrams. 4 to 8 years, they need 10 milligrams, and then puberty, 14 years to 18 years, they need 11 milligrams in boys or 15 milligrams in girls. That's all more than a grown man needs. So you can see how it can be easy to become iron deficient when you're growing. Pregnant women will need more iron because of aforementioned reasons. Women with menorrhagia, they're going to require even more iron than other women because they're losing more blood during their cycles. Malabsorptive states, they aren't absorbing as much iron. Frequent blood donors, just because you're getting rid of blood. Patients with cancer or heart failure, and then also importantly, vitamin C deficiency. We don't see vitamin C deficiency a lot in the U.S., but it's a good physiologic note to remember that vitamin C acidifies the milieu, and that increases the absorption of iron. Manifestations of iron deficiency, you can probably guess what they are. They're going to be consistent with anemia. So fatigue, paleness, weakness, tachycardia because of the higher oxygen demand, shortness of breath, the nails can become brittle, and then we see this in children. It's going to be more like the child might be actually outside and maybe like sticking dirt in their mouth. Whereas if you see this in adults, it's not going to be as dramatic. But one way you can see this is if you have this craving to chew on ice. You see people chewing on ice. That could be a sign of iron deficiency. So pica also includes chewing on ice. And then, especially in children, their weakness and fatigue can actually manifest as a poor appetite, just because they're not going to want to eat. They're too tired. As a side note, restless leg syndrome is associated with a low serum iron. So anytime you have a patient who complains of restless leg syndrome symptoms, so they have difficulty sleeping, they've got their legs are uncomfortable unless they're moving them, then one of the things you should do, apart from maybe sending them off to neurology, but one of the things you should do as a primary is get their serum iron levels, or at least get a CBC with a smear, because there are some patients who have restless leg syndrome who are iron deficient, and an iron supplementation can actually reduce some of those symptoms. And of course, if they're anemic to begin with, we want to treat them anyway. The workup for iron deficiency, if we suspect iron deficiency, of course, we're going to get a CBC. That's going to show a low hemoglobin, a low hematocrit, a low MCV, which shows you that we have a microcytic anemia, and a wide red cell distribution weight. Now, if you have a low hemoglobin, a low hematocrit, and a normal MCV and a wide red cell distribution weight, at that point, and it's important to think of because remember we can have multiple nutritional deficiencies at the same time, at that point you should think maybe we need to get folate and B12 levels. Maybe we should check the homocysteine and the MMA levels because if you can have, at the same time, you can have a microcytic and a macrocytic anemia, and those will average out to a normal MCV. So anytime you have a normal MCV, but otherwise you have a CBC that looks like iron deficiency, go and get homocysteine MMA levels because you might have a folate or B12 deficiency. Usually it's going to be folate, but check both. The iron studies you can get, it's going to show a low serum iron, low ferritin, high TIBC, and high transferrin, and that is the picture-perfect scenario of iron deficiency anemia. Your management is going to be iron supplementation, then recheck in a month. You should manage the underlying cause if there is one. So things like celiac disease seems to be a lot more common. We're detecting it a lot more. That can definitely cause anemia. I've seen that many times. And so that's something that can be managed with a change in diet. Remember, you diagnose that with anti-endometrial antibodies. If they're patients over the age of 50 and they have GI symptoms and they present with an iron deficiency anemia, they are going straight to the gastroenterologist for a colonoscopy. So patients over the age of 50 who have iron deficiency anemia, if they come to you, you're sending them to the gastroenterologist. They need to get a colonoscopy immediately, because we're concerned that the source of blood loss is a possible cancer. So acute iron poisoning between 1983 and 1991, so about 25 years ago, acute iron poisoning made up about 2/3 of poison deaths in children, and this has since dropped since manufacturers now label iron supplement bottles with warnings, keep out of reach of children, and child-proof caps. So the cases now are still typically limited to accidental poisonings in young children, and that's due to the significant amount of iron that needs to be ingested to cause acute symptoms. So you're not going to get this from food sources. You're going to get this from accidentally ingesting too many iron capsules. And who usually does that? It's children. If it's anybody else, then you think of possibly they were trying to commit suicide or something like that. But usually this is going to be in children. The symptoms, early on, there's going to be abdominal pain, nausea and vomiting, diarrhea. You might see some blood in the vomiting, and that's just because the iron tablet itself can cause a little bit of inflammation around it, and that can irritate the tissue. You can get a little bit of blood from that. After these early symptoms, it kind of relents a little bit, and the symptoms might resolve, but then you start to get problems related to the liver. Even though you're not in real liver failure yet, the liver is going to start to malfunction. So you're going to get a coagulopathy. You can get shock and seizure, fever, metabolic acidosis. Now, as the liver starts to cirrhose, you can have some liver failure. You'll continue to have a coagulopathy, jaundice, and hypoglycemia. And then if the patient survives 2 weeks plus chronic long-term symptoms, you can have gastric outlet syndrome because of irritation and scarring in the stomach. You can also have duodenal scarring, which can lead to obstruction. So how do we manage this? Well, the history is generally pretty obvious. Mom or dad or caretaker finds child with the iron capsules, the bottle. There might have been 30 tablets in it, and now there's none. So based on the history, you can make a presumptive diagnosis. But workup is going to be really important for documentation and for planning your intervention. So, of course, we're going to get basic routine labs, CBC, BMP. We want liver function tests as a baseline. We want serum iron levels, of course. That's going to tell us how severe this is. We want arterial blood gases because these patients are at risk of going into metabolic acidosis. And then I boldface this here because you might not think of this, but this is actually really important. Abdominal X-ray. These iron tablets, they take some time to dissolve. Some of them. And so if you do an X-ray and you can see the iron tablet still in there, you can actually do a lavage and get irrigate some of those tablets out. So what do we mean here? So if the tablets are seen on abdominal x-ray, you do whole bowel lavage with polyethylene glycol. In adults, it's 1 to 2 liters per hour. In children, it's 25 to 40 mils per kg per hour. And then you'll just do this and repeat the abdominal x-ray, continuing the lavage until no tablets are seen. And that's going to reduce the amount of absorption of any residual iron tablets that are there. But overall, so you have a patient we know has acute iron poisoning. We've done our initial workup. We're going to admit them generally to the ICU. We're going to be getting serial routine labs, liver function tests, serum iron levels, and arterial blood gases. We want to keep an eye on the serum iron levels because after a certain level, and that's 500 micrograms per deciliter, but after a certain level, if it exceeds that level, then we need to do deferoxamine, which is chelation. And then we need to look at arterial blood gases because of the risk of metabolic acidosis. We'll have these patients on IV fluids, and then you should also contact the Poison Control Center or a staff toxicologist who might be able to give you advice or even take over the case. So if there's decompensation, and those things would be something like metabolic acidosis, shock, severe enterocolitis, or diarrhea, which is interfering with the hydration status of the patient, or if the serum iron goes above 500 micrograms per deciliter, then you start deferoxamines, and you have to have IV fluids with the deferoxamine therapy. Hemochromatosis is not an acute iron poisoning. This is a chronic disease that people carry genetically. 1 in 10 Americans carry the most common allele for hemochromatosis, but only 4 in 1,000 are actually affected by the disease. So you would expect that if 1 in 10 Americans carry an allele for hemochromatosis, that mathematically 1 in 100 people should carry the disease. Right? You got recessive plus recessive, that makes up 1/4, and so that's 1 in 100. Right? I think I'm doing that right. So anyway, it's about 1 in 100, but only 4 in 1,000, which is 1 in 250, are actually affected by the disease. So this suggests that some people may be affected by the disease, but they don't really have symptoms. Or it's just has variable penetration, meaning that it's not severe enough to cause symptoms, or it's subclinical. Management. So long-term management for hemochromatosis is follow-up with a hepatologist. Patients will require long-term hemodilution, which is just a phlebotomy. So it's basically just like you're going in to donate blood. And then the thought of that is that you're getting rid of red blood cells, which have iron in them, and so you're reducing your body's iron stores. Or deferoxamine chelation may be done. That's usually a second. That's usually a second choice. We try to do long-term hemodilution. The hemodilution is it's much easier, and there's very few side effects from it. We want to monitor their liver function. If cirrhosis develops, then you'll want to see them every 6 to 12 months for alpha-fetoprotein levels and sonography, because at this point then we're concerned about the possible development of hepatocellular carcinoma. And that's one of the long-term complications, and along with cirrhosis, the leading cause of death in people with hemochromatosis. All right, so moving on to iodine. Iodine deficiency used to be a big problem in the U.S., and it still remains a problem in the developing world and also parts of Eastern Europe. It's not so much a problem here now because we have iodized salt, and so it's very easy to get sufficient amount of iodine. Most salt that you run into now is iodized, and you only need a half a teaspoon of iodized salt to get all the iodine you need for the day. So it's very easy for us to do, especially in our diet in the U.S., which it's a very salty diet. Now, in the past, it was a lot more difficult to get their iodine for two reasons. One, they didn't have iodized salt, and two, the amount of iodine in the soil in different places in the country uh, didn't have the same amount. You didn't have the same amount of iodine in New Hampshire as you maybe had in California. And so certain areas get would get goiter from insufficient iodine um, intake, and so that's why they would call it endemic goiter, because it would be endemic to a specific area. Now, again, we don't run into a problem even from that because all of our food is shipped in from all different places now. So iodine, as you know, is a component of thyroid hormone, so it makes sense that if you have a deficiency of iodine, it's going to lead to a goitrous primary hypothyroidism. And in severe cases, it results in endemic myxedema, which is similar to myxedema coma in patients with non-iodine-related hypothyroidism. Chronic deficiency in iodine or deficiency of iodine in the mother while she was pregnant with the child results in poor growth and intellectual handicap. This is commonly referred to as cretinism. So the sources of iodine in the U.S., generally we get all our iodine from iodized salt. Half a teaspoon of salt has 200 micrograms, which is way more than anybody who's not pregnant needs. Baked potatoes are another good source, milk, seafoods, navy beans, cranberries, and yogurt. I like that Greek yogurt stuff, so that's a really good place to get it. The recommended daily amounts of iodine, you can see they vary based on age. If you're pregnant, you're going to need more iodine. And then if you're breastfeeding, you need even more iodine. And so why is this different? Remember, we needed less of the iron when we were breastfeeding than normal, and now we need more iodine during breastfeeding than normal, and that's because, well, you don't lose iodine when you're menstruating, so you're not saving yourself anything. But you want to get a good enough concentration of iodine in the breast milk. So the iodine requirements go up during breastfeeding. Here's iodine deficiency. This is just a goiter. So you see this, you see a goiter. Okay, you can't say it's iodine deficiency without a history. This is iodized salt. And it says on here, this salt supplies iodine, a necessary nutrient. So magnesium is necessary for a lot of different things. It's seen everywhere in the body. It's used for enzymatic processes. It's going to be found in pretty much any kind of tissue because it's used for metabolism. Deficiency is notably associated with derangements of other ions, particularly hypokalemia and hypocalcemia. And the reason for this is because a lot of those ATPase pumps work partially with the help of magnesium. So derangements of, let's say, potassium or calcium in the presence of a magnesium derangement can be really refractive to therapy. As long as the magnesium level continues to be low. And so if you have a patient who has hypokalemia or hypocalcemia, it's always good, if there's ever any metabolic derangement, to get a magnesium level so that if the magnesium level is also affected, then you know, well, if we correct this, then that will help us correct the other deranged ion. The sodium-potassium ATPase in the heart muscle cells require magnesium to work properly, and magnesium deficiency can result in tachycardia as well as QT prolongation, and that ultimately can result in ventricular fibrillation or Torsades de Pointes. Magnesium also has a vaso and bronchodilatory effect. The vasodilatory effect is why we give magnesium sulfate in women with preeclampsia. People at risk for magnesium deficiency include alcoholics, especially those in withdrawal, also patients with thiamine deficiency, and that tends to be the alcoholics. Those who are on diuretics, and this is actually, diuretics is the number one cause of iatrogenic hypomagnesemia. proton pump inhibitors, aminoglycosides, people who are diabetic, malabsorptive states, and then some of those renal diseases, those renal channel diseases, Gittleman syndrome and Bartter syndrome are two. So this is QT prolongation. Remember how to do your QT interval. So this is just the same ones, just zoomed in. So where's our QT interval? Here's the beginning of our QRS complex, so that's Q, and there's the end of our T, so that's T. So the Q to the T, remember a normal QT interval is 0.4 of a second, so 400 milliseconds. That's going to be 2 big boxes because 5 big boxes is 1 second. So if you look here, you see that we've got a QT interval of about 600 milliseconds. So this is definitely prolonged. And if you have a prolonged QT interval, this is one of the feared things that can happen, Torsades de Pointe, which ultimately can lead to ventricular fibrillation, and then that's a very common cause of death. So that's the reason why with Torsades de Pointe, the first step we do, besides our ABCs, is to get the patient IV magnesium. So our sources for magnesium are nuts, particularly almonds, spinach, beans, edamame, shredded wheat cereal, soy milk, peanut butter. I only learned what edamame was when I was in my first year of medical school. I thought it was, I was kind of creeped out. It looked like peas to me, but actually pretty good. So the workup, you get plasma magnesium levels. The lower limit of normal is going to be less than 1.7 milligrams per deciliter. If there are electrolyte derangements, as I mentioned, it's advisable to get a serum magnesium level in the event of hypomagnesemia, and it will aid correction of the other deranged electrolyte. And Torsades de Pointe, it's a polymorphic ventricular tachycardia that can devolve into a ventricular fibrillation, and so you should administer 1 to 2 grams of magnesium over 30 to 60 seconds. All right, so zinc is one of nature's stronger antioxidants, actually stronger as an antioxidant than vitamin C. And it's a critical component of various membrane proteins, like the zinc finger proteins. It's also required in immunity and in testosterone production. There is a growing prevalence of zinc deficiency in the U.S. because of our more processed diets. We tend to eat white bread over wheat bread. And so because of that, because of the processed nature of our diets, we're not getting as much zinc. And a lot of people are actually zinc deficient, even though it's subclinical. The effects of zinc deficiency are diverse and pretty nonspecific. They include decreased immune function and impaired wound healing, oral ulceration, like canker sores, angular cheilitis, stomatitis, dermatitis, acne, seborrheic dermatitis, and then this really particular thing that can happen to your nails called leukonychia. Now, zinc is not the only thing that can cause leukonychia, but when you see, and you see a lot of people and even children with leukonychia, a zinc deficiency should be something that you think of, and it might not be a bad idea to get a zinc level and see, or at least encouraging the parent to provide foods to the child that have sufficient amount of zinc. But in the U.S., most cases of zinc deficiency are subclinical. Populations at risk for zinc deficiency, pretty much the same crowd as before. So pregnant women, growing children, alcoholics, malabsorptive states, including bariatric surgery. Patients with copper excess, so the reason here is copper and zinc compete. So if there's a copper excess, you tend to have a zinc deficiency. If there's a copper deficiency, you tend to have a zinc excess. So particularly Wilson's disease is where we see the copper excess. And then a condition called acrodermatitis entropathica. And these people aren't just at risk for zinc deficiency, they have zinc deficiency because they have a mutation of a channel that's supposed to transport zinc. So this is that leukonychia I was telling you about. You see a little bit here too. These little white spots on the cells are can be a sign of zinc deficiency, but there are a lot of other things that can cause this. Um, a lot of those other things, though, are more severe. So when you see it in the American, it's probably a secondary to the zinc deficiency. And then copper. So copper plays an essential role in the development of heme. It is sort of a cofactor of ALA synthase. ALA synthase needs copper to work properly, and remember, ALA synthase is the very first step in heme synthesis. It converts succinyl-CoA to ALA, aminoleuvolinic acid, I believe. It's also important for proper collagen development and nerve function. So copper deficiency in the United States is quite rare, but if you have a significant enough copper deficiency, it's going to look just like iron deficiency because you're not making heme. So you'll have a hypochromic microcytic anemia, but if you get your iron studies, they won't reflect low body stores of iron. Other manifestations of copper deficiency include weakness, neuropathy, and osteoporosis because of the collagen issues. Patients at risk include premature infants, people who are malabsorptive, people who are taking too much zinc, or people with something called Menkes disease, which is autosomal recessive. It results in a copper deficiency. You don't even need to know about that for the test. Copper excess is seen most notably, of course, in patients with Wilson's disease, and that's going to result in liver disease as well as neuropsychiatric symptoms. So I believe the technical name for Wilson's is called hepatolenticular degeneration, and so that's referring both to the liver and the central nervous system. So the liver disease, they do develop ultimately cirrhosis, they can develop cancer in the liver, neuropsychiatric symptoms, they can be epilepsy, they can appear psychotic, and then you sometimes, not all Wilson's patients have these, but when you do see these, it's pretty much pathognomonic, these Kaiser-Fleischer rings in the eye, and they're kind of greenish looking. And so this is heme production. This is that first step where you need copper. And we go through all these steps, and then we wind up with hemoglobin. So, I had to put this in here, so I'm such a nerd. Okay. So in Star Trek, right, the Vulcans, which were an alien, their blood was supposed to be copper-based, just like ours is iron-based. And so when you look at like where they bleed, it turns green, and that's just like what you see in people who have the Kaiser-Fleischer rings. So when copper gets oxidized, you get this reaction, and it's also the same thing we see on the Statue of Liberty. When France gave us the Statue of Liberty, it was actually like a goldish copper color, like a penny, and over time, it's just oxidized, and now the Statue of Liberty is known to be this green statue, and it was never really intended that way. Deficiencies of other trace nutrients, so manganese helps with the production of connective tissue, blood clotting factors, and sex hormones. Also has antioxidant properties as part of SOD. Molybdenum deficiency can lead to dental caries, susceptibility to asthma, and gout. Cobalt is a part of vitamin B12. Remember, it's cobalamin. Cobalamin is the name for B12, and cobalt is in that complex. And that's necessary for the synthesis of blood cells. Deficiency can also result in neuropathic symptoms, which we talked about in the vitamin section, including tinglings of the hand and feet, difficulty walking, and ultimately dementia. And then finally, chromium. This deficiency is really rare in average walking people, but people who are on TPN diets that don't contain enough chromium, this can be problematic. So they would exhibit loss of weight, glucose intolerance, confusion. So I would know the first 4 or 5. These not so much a concern. But definitely know what happens if there's a deficiency, or some of the things that can happen when there's a deficiency. Definitely know iron. Definitely know iodide, as far as that it causes endemic goiter. And then I think with that you should be good. So let me know if you have any questions.